And we are live with the very wonderful Dr. Michelle Griffin, who is a gynecologist, I can't even talk, gynecologist, obstetrician gynecologist, now turned brilliant sort of tech guru and BBC science columnist, and has just written a book on fibroids. Show us that cover.
Yes, I literally just got it this morning. I'm very excited. Woohoo!
Yeah, look at that. So no better person to talk to at the moment about what is going on with bleeding. And as we know, bleeding in menopause can be hell, bleeding in perimenopause can be hell, bleeding before menopause can be hell, bleeding is just generally hell. And there are multiple reasons for it and various different scales of, you know, what may be considered normal and what may be considered common. So we will be running through a lot of these sorts of things. But so let's sort of start with that then. If we're talking about before menopause, or what's common and what's not common, because we know that people go through, you know, perhaps decades of living in excruciating pain for various different causes of incredibly nasty bleeding, like endometriosis, adenomyosis, fibroids, all of those sorts of things. What is the difference between normal and common?
Yeah, I think that's a great question. And I think it's actually incredibly common to have bleeding that is not normal. But the problem comes is that most women will start their periods as young girls, teenagers, and they will often follow a very similar pattern to what their mother, their sisters, their aunts, etc. will be experiencing. And that then gets, oh, well, this is just how we bleed. These are the pads or the period products that we use. This is how much we bleed. This is how long we bleed. This is how painful it is. Or during your mid-cycle or whenever, this is when we get this pain. And so it gets normalized in the most sort of benign way. No one's trying to dismiss that young girl at all. And it's just saying you're experiencing what we experience. And I can definitely speak to that with both my daughters, that you'll say, this is what I do. And they want to know that. The problem comes is that if that family of females has actually been experiencing abnormal bleeding, then that young girl starting her periods will grow up and continue to think that actual abnormal bleeding is completely normal. And this is what throws so many people off. Then on top of that, if there is something that triggers them to go to the doctors, which could be related to the bleeding, or it could be something completely different, and they just get asked, what are your periods like? The default, common, typical response, and I hear that so many times as a gynecologist, is, oh, my periods are fine. Fine, they're fine, they're fine. We just hear that and we just accept that and we don't push or prod any further. But I think if we go all the way back and say, well, what would we say is abnormal bleeding? I would say anything, when we're just talking about a period now, rather than bleeding outside of when you're expecting a period. That is something completely different. But bleeding on your period, it is a problem if it is a problem for you. And that's as simple as it needs to be. And that's not for me as a gynecologist or a GP, your partner, your mother, your friend, to explain whether they think it's a problem or not. If you find you cannot do what you normally do, then, you know, when you are not on your period, then it's a problem. And it was really great to see that when you see GPs talk now, a friend of mine said just the other day, last week, she said, I always will actually give some context, give some examples. So she said, when I say, do you find your periods a problem? She's actually pushing to say, do you have trouble sleeping with it because you're leaking through your period products? Are you having to use more than one type of product at any one time? So this typical kind of double protection where you're using a period pad, possibly on top of an incontinence pad, on top of actually an incontinence pad that sits in your pants, but then actually a large square incontinence pad that lays on the bed. If that's the level you're at, then that obviously is a problem. But again, I can say that as obvious. That's not my experience. and that's not what I've grown up with. But that would seem too much to you. Even if you've grown up, you shouldn't need to have this much period product to actually protect yourself from your bleeding. And it is that you are bleeding too heavily.
My God,
Equally,
if that were happening to me, I'd think I was hemorrhaging and I was going to die. I probably would have taken
sure,
myself up to the hospital.
but you would be surprised, and I can definitely say, like, how many women live with this on a normal basis, and how many of those women are bleeding that much, to the point then that not only is it just the practical impact on their life, but also the emotional and mental of having to prepare for this, and have we got enough products, and obviously I can't ever not be at home, I can't go on a work trip because there's no way I could potentially leak in a hotel bed, etc., etc. But also, if you're bleeding that much, I can be pretty sure you are anemic. And that is going to have so many other repercussions and consequences as well. So number one, you're going to be exhausted all the time. And it is really bad, because so often in society we say, oh, you're a woman, you're at a certain time of life, you've got children, you're trying to do a job as well, etc. You are going to be tired. Everybody's tired. It's this time of the year, or it's that, and whatever. But you will be bone tired, and it is completely and utterly understandable if you are bleeding that much. Even if you say, oh, I only have short periods, like 2 or 3 days, still, if you're bleeding that much, I would bet that you are anemic, and therefore that's going to make you super tired. But we also know long-term anemia can have complications further on in life. So we're starting to see a connection with the heart health of a woman if she's actually been suffering from long-term anemia. So we've seen some really interesting association between anemia and abnormal heart rhythms, such as atrial fibrillation. And what we're actually seeing comes back to my point of why I wrote my book about fibroids, is number one, fibroids is the biggest cause for heavy bleeding. And number two, most women who have atrial fibrillation who are then found to be anemic have probably got fibroids as the underlying cause of all of this. But this is, as you say, has gone on for years and years and years. This doesn't just happen overnight. This is 10, 20 years of having these heavy periods that have perhaps got heavier as you've gone through your life. They've lasted longer, and you've just thought, well, this is just part of aging, or this is just part of what happens after your body's had a baby, for example. And in actual fact, this is your wake-up call to say, if you've had that little question in your head of going, does everyone bleed as much as this? That's not the question. The actual question is, this bleeding is impacting you, and it is definitely time that you go and get help for that and go and speak to your GP about it.
Yeah, absolutely. And actually, just listening to that, it makes me think that I need to add to the charity site a little symptom thing about bleeding, because it's all very well to ask somebody, you know, are your periods a problem? And if they're thinking, well, that is my norm, then we really need to ask those specific questions in the end, don't we? Like, do they wake you up? How many period products do you go through? You know, do they stop you from doing things, just making it unbelievably like a real granular?
Yeah, exactly. Going through it, because it's, you know, obviously, and I can speak as a woman who has had periods, you are nervous about, oh, am I going to come on my period? Am I going to leak? That is, you know, it's, I was about to say acceptable, but I didn't want to say it's okay, but it's
a
like,
reality.
that would be a reality of the fact that anywhere bled from, you wouldn't want to leak through your clothes, sure that your plaster's covering it, etc. But if you are so at the point that you know, that's at the forefront of your mind during your period, and you are worrying about that during your period, and that's happening like almost every, if not every single period, then again, that's a great sign to say, something's not right here. Especially because, you know, as I say, fibroids are the number one cause for heavy bleeding. There are other causes, but most of the causes can in fact be treated. And so we are doing, you know, it is worth going and getting that help and getting treated.
Yeah, somebody's actually asked a question over on the Instagram, actually. So what are the symptoms? Before we get to that. How, I mean, a lot of people, they're very, very common. I mean, I even had an ultrasound the other day and they said, did you know you've got a fibroid? And so I sort of asked the doctor
you're like,
the results
no.
came that came. I was like, that's new actually, because I didn't have one last time. So I asked where it was and she didn't tell me where it was. She came back and saying, they're very common, you don't have to worry. And I said, well, that's not the question I asked. But that aside, how common, I just wanted to know where it was, that's all.
No, that's really important. I will come to that in a moment, actually.
Yes.
But yeah, how common are they? Yes,
and when do
incredibly common. So in the UK, from the data that we have so far, and the reason I will come back to that in a moment, but from the data we have so far, we think about 70 to 80% of women have fibroids by the time they reach the age of 50. So if you're in a group of 5 women, if you think to yourself of your friends, that the mums in the schoolyard, whatever, 4 of you will have fibroids, and you would be unusual to be that one person who doesn't have fibroids. They are this common. And when we look across the whole world, because there is an element of genetics and ethnicity, etc., that plays into the causes behind fibroids, we see it to be about 2/3 of women have fibroids. So, this is something that is affecting women worldwide. The reason why I say about this is what the data says so far is that, unlike a lot of other medical conditions, many women live with fibroids and never know about it. And they will say right up to the point of menopause, and then their periods stop, and then 10, 20 years down the line, and then they'll see their daughter or their granddaughter, for example, talking about their heavy periods, only for them to say, oh, I used to have the same heavy periods. And probably this is a family, genetic caused that's running through the whole family, where each and every one of them, it has got fibroids. And yet that will never get picked up. It will never get registered. And equally, things like yourself, Fiona, where it was so often people will be having a scan for another reason and find the fibroid. And even when they've got that, and that's all it needs as a diagnosis, it's nothing fancy. We're not talking about full-on surgery, a load of blood tests coming in and out of hospital. Most fibroids, if you have them, can be picked up by an ultrasound scan, which we are doing quite often in women for lots of different reasons. So you'll see it in pregnancy, infertility treatment, being investigated for painful periods, being investigated for chronic pelvic pain, being investigated for something that has nothing to do with your reproductive system. It's very common to get an ultrasound of your tummy and pelvis at some point in your life. And often women are told, oh, by the way, incidental fibroid found. But of course it's not incidental, because what should be happening at that point is to say, gosh, fibroid has been found. And using you as a great example here, Fiona, and actually running through a checklist to say, right, we found a fibroid. Do you have any of these symptoms that were linked to a fibroid? Because if you do, that is us then investigating and treating that fibroid. Because how on earth does a sonographer or a doctor, I'm not talking about who the person is who's doing the scan, but how on earth does someone who's not you, who doesn't ask you the questions, know whether you've got any symptoms of fibroids or not? It's just crazy, isn't it, to just assume that, oh, you'll be fine and it's an incidental. There's no
I guess
such
that comes
thing.
back to things like, you say that, they're very common. And as you said, most people, a lot of people will not even know that they've got them, and they don't appear to be causing them any problems. So therefore just ignore them until they cause them a problem. Is that the thinking? I don't know.
I think that is the thinking, but then the thing is that they probably have actually been causing problems. And where that line, it seems, has been set of, we will wait until you get these types of problems, or more so this degree of problems. So, for somebody who's saying, I'm bleeding so much on such a regular basis for such a length of time during my periods, and every month I'm having to go in and have a blood transfusion, that would be like, that now warrants us to do an ultrasound and you've got fibroids and we're going to treat them. But it shouldn't, and that's the whole point, it shouldn't have to take as severe level of disease and symptoms to trigger the medical profession to say we should be doing something about it. And what's great is the Royal College of Obstetricians and Gynaecologists just last week launched a brand new report and recommendations highlighting this exact point, which is to say, we need to bring forward earlier diagnosis. And it's very similar to what we talk about across the whole of healthcare around earlier diagnosis of cancer, of let's not wait for this condition to cause the most extreme level of impact on you and cause you to be so ill and potentially at a life-threatening illness needing blood transfusions because you're losing so much blood from your heavy periods. Let's actually pick people up potentially earlier. So, for example, like yourself, where there is an incidental finding of a fibroid, you're actually actively asking that person, do they have any symptoms? Because you're sort of screening and saying, these are the symptoms we'd expect to see with a fibroid. Do you have them? If you do, even at a minor level, let's put a plan in place. Also, we should be screening people, using an ultrasound potentially to say, your family has known to have fibroids. It is likely you are going to have fibroids. Let's be doing a check on you every, 5 years, 10 years, etc. These are the symptoms you should be looking out for.
Yeah, and the unfortunate thing too is I think it was Basil Watter did a study on socioeconomic and ethnic diversity in these things, and found that basically if you are poor and black, you're far more likely to end up in hospital with a blood transfusion, and nobody should get to that point. So
exactly.
Apart from, that's just outrageous. Apart from the incredibly heavy bleeding, are there other symptoms that people should put together to think, oh, hang on a second, this could be a fibroid?
Yes, and just before I go into it, I just want to touch on about location of fibroid. Now, obviously, when you're at home and you're thinking, this sounds familiar, I've got these symptoms, I'm not suggesting you're going to know the location of the fibroid. You get the location of the fibroid once you've had the ultrasound scan, which is exactly right. What I always recommend, and I've walked through in my book, there's lots of sort of checkpoints in the book to say, this is your symptoms, these are your symptom records. If you're going and having a scan, these are the questions you should be asking. These are the questions you need answers to. Build your own fibroid fact file so you know the ins and outs of exactly what's going on at that point in time. So then when you have follow-up scans or any treatment, you know if and when things are changing and how they're changing. The reason why it's so important to understand about the location is because location matters more than the number of fibroids or the size of fibroids. So somebody can have a very large fibroid, and many celebrities, for example, Venus Williams has talked about how much fibroids has affected her and really impacted her tennis career. But she's had fibroids of massive sizes, orange apple size. Some people can have them as small as peas, but the size is obviously going to have an impact, but more so is the location. Is it on the very inside of the womb? Is it in the middle, bulky muscle layer of the womb? Or is it just sitting on the very outside layer? Exactly, I love this. So yes.
I'm an artist, aren't I?
You're a beautiful artist. And depending on the location of your fibroid, it really matters about the symptoms that you would experience. So talking about heavy periods and or painful periods, they are typically associated with fibroids that sit on the very inside of the womb near the cavity, which is where the lining of the womb is. And Fiona will point to it now. So they might sit on the inside of the womb or that muscle layer called the myometrium that is like the bulk of the womb. But it all sits like basically on the inside of your womb. If though you're getting pain, that typically will come from the fibroids in the muscle layer, or if you're getting a lot of pressure symptoms. Now, typically, these are coming from fibroids that sit more on the outside of the womb, but it can also come from a very large fibroid or lots of fibroids that have just basically made the size of your womb bigger. So a normal womb should be around the size of a pear. And, your womb can get bigger than a full pregnancy womb due to the size of the fibroids. And I've operated on wombs as big as that. Now, if you can imagine that, you are going to get a lot of pressure on the other organs of your body. Just like we talk about in pregnancy, you will get similar things. You get pressure on the bladder, you get pressure on the bowel, and you get pressure on the vagina. Walking through those things, if you get pressure on the bladder, you're going to feel like you can't hold your wee very well. You need to wee all the time. It won't hurt, but it will just feel like you are constantly weeing during the day and during the night. And that is literally because you've got a large fibroid uterus pushing down on the front bladder just here. And that bladder just can't expand as much as it once did, so it stays small and it just feels irritated from this pressure pushing down all the time. If you've got the same thing, but now I'm going to change my hands, I'm going to the back, you've got a large fibroid uterus, and I'm going to just pretend to sort of be the bottom end of the bowels here, which is sort of like sigmoid down to rectum part of the bowels, which is where your stool will sit ready to go to the loo. This will push back against that, and it will really lead to a lot of feeling like you may need to go to the toilet and open your bowels, yet nothing comes, or more typically, you get an awful lot of constipation. So quite often you'll get women who will say, my periods are fine, maybe a bit heavy, but I feel bloated. That's another common one. I feel a discomfort down below, and they can't really point exactly where it is. And that's usually telling me that you've got quite a large uterus filled with fibroids, maybe one big one, maybe lots of smaller ones. And it's just the weight of that pushing down on the organs like the bladder or the bowels, as I've talked about, but also pushing down on that pelvic floor that sort of sits a bit like a nice trampoline and should be quite taut. But if you have a lot of pressure from a heavy uterus full of fibroids, then it starts to sag and you just don't feel as supported and you feel uncomfortable. So
do you get lower back pain as well?
Yeah, definitely. So in that way it is, and this is the kind of brutal irony, it can mimic pregnancy symptoms in so many ways. But of course, the other thing is the complications of fibroids, not just these symptoms we talk about, which are very difficult and intense as they are, but also the fact that, they have a massive impact on your ability to conceive, to be fertile and actually become pregnant. They have a massive impact in those early few weeks of pregnancy. So you may be able to become pregnant, but you may suffer from recurrent miscarriage. So we would deem that to be those early miscarriages up to 12 weeks. You may also suffer from later miscarriages because as the baby grows and the pregnancy continues, you're getting more and more estrogen, and fibroids love estrogen. Estrogen is like a fertilizer to a fibroid, and it just grows and grows and grows. So as the baby's growing, the fibroid is growing, and usually the fibroids will grow very quickly because you've gone from a not pregnant state to a suddenly pregnant state where your estrogen is much higher. And the fibroids, there is a twist here, is that not only do they absorb estrogen as a fertilizer, they can actually develop their own estrogen receptors. So they can actually get more, they can kind of absorb more and more estrogen the bigger they grow, not just because of their size, but because they actually make more kind of handles to be able, like nets to catch the estrogen. And so this is why they are super greedy. They're horrible, horrible, horrible things that will cause often a lot of complications in pregnancy and also at delivery, because it's about, again, as I like to say, Phil Spence, location, location, location with Kirsty Allsop. Where are these fibroids? What are they doing? And what does that mean for a baby growing, for going ahead and having a delivery? Can it be a vaginal delivery? Does it need to be a cesarean? Because if you've got a fibroid, if this is the baby here at the top of the uterus and a fibroid sat here, that baby is not coming through the vagina down here. It's, that fibroid is blocking it. So often we will do a cesarean purely because we can't get past the fibroid. Often you can get fibroids also growing in the neck of the womb, the cervix, and they can cause a lot of problems during delivery. And the worry is going into labor, because as soon as the cervix starts to open as part of delivery and labor, the fibroid will then bleed, and they bleed very, very heavily because they're just so vascular, because they've been living off all these masses and masses amounts of estrogen throughout the pregnancy. So these are really complicated, symptoms and complications and consequences, which is why it is so wrong that in medicine, so many people feel that, oh, it's just a heavy period, it's just a period, it's just being a woman, we get all of this in a family, or your family has always struggled with this. Because actually fibroids is, of course, a medical condition, but it really has a massive impact on women and on so many women. So we must do an awful lot better in kind of finding these fibroids, monitoring them and treating them.
Absolutely. And a question over there on Instagram as well, asking, well, how do you treat them? And honestly, I'm just sitting here thinking to myself, you shouldn't have written a book, you should have written a horror film.
Well, interesting you say that, because on Disney, there is a short film all about a woman who had fibroids. It's a very short film. I can't remember what it's called now, but it's, really interesting. And, the biggest comments that came back when this film was released was, as ever, you and me, Fiona, we talk about so much in women's health, of so many people saying, oh, I didn't realize that, along with so many women going, yeah, that's me. That's what I've been living with. And I either thought that was normal, or really brutally, I went to a doctor and I got dismissed and I got told it's nothing and this is just what people do. And I remember I just saw the other day, Vicky Patterson, who I believe struggles with PMDD, so something completely different, but a lot of kind of hormonal changes that happen around periods that lead to significant mental and emotional changes. And when she went to the doctor, you know what the doctor said to her? She said, all women have periods. Some women are better at dealing with them than you are.
Wow.
So I just want, if anyone's seen this, please, that would be my key message. Please don't accept that. And it's totally wrong. There's no way to excuse it. But what can really help is to actually try and understand your own body more and keep pushing. Go and see another doctor. Go with your record of symptoms and say, this is what I'm actually experiencing and this is not okay and I need someone to help me with it.
God, absolutely. That's just an absolute shocker of a comment, isn't it? I mean, that really is. That's just, God, that takes your breath away. Okay, in terms of treatment, I'm guessing the person on Instagram is asking because they too probably haven't had a lot of joy in getting any treatment.
Yes.
So what are the treatment options at different stages of people?
Yeah, great question. So treatment is a very big subject. It's actually taken like 3 big chapters in my book, actually. It's really big because there are lots of different treatments. And as I describe in the book, what's the most important thing is, one, understanding there's lots of different factors that feed into the treatment that you will get. And I will speak about that in a moment. But secondly, the biggest factor that feeds into it is you being clear about what you want to do, what you're comfortable doing, what you want to do. Some people, in my experience, have come to me and said, I've been living this for 20 years. I'm fed up with it. I don't want to go through very gentle treatments and work my way up. I'm 48. I don't need my uterus anymore. I want to go ahead and I want to have some surgery of some kind. Not necessarily a hysterectomy, but surgery of some kind. That is obviously completely different, potentially, to a woman who's 25 or 35 or even 45, who's saying, I just found out I've got a fibroid. I'm just coming to terms with that. These are my symptoms. I'd like to just start with the lowest level of treatment. So it's just really being clear. And in my book, I give some really good kind of prompt questions to say, these are the kind of things that I want you as a reader to think through and say to yourself, what's important to you? What's your number one thing that you want to achieve? How do you feel about having surgery? How do you feel about taking a medication and then realizing that that hasn't worked? Because there's no way to predict what will work, what won't. If that's going to really annoy you, if that doesn't fit in with your life, Do you want to go for something that's more interventional? How do you feel about the risks that come with surgery? These are all the questions that I wish all doctors sat down and spoke to their patients about, but sadly they don't. So by writing this book, I've tried to give those prompts to the reader to say, if you can think about these things and then go into your appointment with the answers or some thoughts towards the answers, it will mean that you get a much better outcome from your appointment. So it's really useful to just work through those bits in the book. But essentially, there's three types of, well, two types really of treatment. One medical, one surgical. In medical, the vast majority of it is just for time now and kind of, I'm making some big sweeping statements, but the vast majority of medical is based on hormones. And essentially there's two principles or ways that we go about things. One, we just try to give you some hormone, potentially, progesterone that comes through a Mirena intrauterine device that will sit up inside the uterus, or potentially as tablets or injections, etc. And what that's doing is, in some women, that will shrink the fibroid, but in some women it won't do anything, and in some women it will make it a lot worse. And so that's what I mean about trial and error. At the moment, and this is something that why we need so much more research in this area, is because there's no way to assess a kind of woman, her symptoms, the location number, size of her fibroids to determine whether she would respond well to treatment or not. And that just seems really, really difficult. And we would want to improve on that. But that's, relatively low risk. There are some side effects for sure. And it's all about your own personal medical history as ever. But that's one way that we approach things with the medical treatment. The other is a kind of step up, which is where we will give you hormone treatment to switch off your ovaries. So your ovaries normally make lots and lots of estrogen, progesterone, and testosterone. And we give you lots of a hormone that works in slightly different ways. And I explain all of this in the book. But basically, it switches off the ovaries. So you don't produce estrogen, progesterone, testosterone as much. The point there, and I'm sure, Fiona, you're quick enough to think, isn't that going to sound a little bit like you're inducing menopause? Yes, that's exactly right. And that's what I mean about that is a level up of medical treatment. The good thing is it really cuts off that estrogen supply to the fibroids, and they do actually respond really well. The bad thing is it induces menopause. So to live, your quality of life, what you're experiencing, the side effects from this particular type of heavy duty, should we call it, hormone treatment, are quite brutal. Quite brutal all the way to incredibly brutal, and you can't really tolerate it, because as well as it being menopausal symptoms, it's so sharp and sudden, it's really, really brutal. And you can't go on it long term because it has a significant impact on your bone density. And the worry is that you lead to having a high risk. You're pretty much sure to get osteoporosis if you're on it long term. And when we talk about long term, we're talking about sort of 6 to 12 months is a bit of a query area. Over 12 months is definitely what we would be calling long term. So you'd kind of take it for 6 months. The fibroid would shrink, you'd get some really good relief from your fibroid symptoms, but in some ways you're getting replacing it by these awful menopausal symptoms. So the hot flushes, the night sweats, the real dryness of the skin, of the vulva, the vagina, the difficulty with the mood swings, the difficulty with sleep, and then obviously the longer term things with regard to your brain, heart, and bone health. So what we now have that just come onto the market in the last year or so is a slightly better version of this treatment, which doesn't cause quite such a bad reaction. And also it's now been agreed by NICE to add back a little bit of estrogen. So it sounds weird, but basically if you think your normal level of estrogen is here, when you take the hormone treatment and it puts your level of estrogen to here, and then I need a third hand here, but essentially you add back a little bit more estrogen. It doesn't stop those, you know, this is where your normal is, and add back gives you about that much more. It doesn't stop the menopausal symptoms, but what it tends to do when we look at women is it gives them enough estrogen to actually cope. That's probably what I would say. But again, these treatments aren't fantastic. They either, the first treatment, which has little in side effects, doesn't often work that well, and the second treatment works really well, but it has horrendous side effects, which is why so many women will find that they move quickly out of medical treatment and into surgery. And with surgical treatments, what you're really looking at is, do I take the fibroid away or do I take the whole womb away? Taking the fibroid away, generally speaking, and this is just by rule of thumb, is a less invasive treatment. So you've got less risk associated with it. Like all surgery has risk: bleeding, infection, anesthetic, surgery time, recovery time. All of that gets lessened if you only work on just removing the fibroid compared to removing the whole womb. But if you only remove the fibroid, you still have the uterus, and therefore, whatever caused you to develop fibroids, there is a high chance that you will recur and develop more fibroids. They're not regrowing from where they were. The whole fibroid is removed, but they're just, whatever caused that first, second, 10th fibroid to come, it's coming again, essentially. Taking out the womb is a much more involved procedure. However, once that's removed, there's no risk of fibroids returning. Unlike a lot of other conditions, fibroids can only actually grow inside the womb. If you don't have the womb, you're not going to grow fibroids. So if you think something like endometriosis, many women will have their womb removed because of endometriosis. But then that doesn't completely rule out that endometriosis lesions will still potentially grow on the bowel, the bladder, the side walls. This is not like this. Fibroids will only ever grow inside the womb. So without the womb, you are 100% sure that you will never get fibroids again. But what you add into all of this is, well, where are you at with the view of your family? Do you know, have you completed your family? Maybe you've not even started your family. Maybe you're not sure, and that's totally understandable. And maybe it's not actually about your family at all. Maybe it's not about whether you want to have children. Maybe it's just that you want to have a uterus. And actually, for many women, for lots of different reasons, they don't want to have a hysterectomy. So it is a really difficult situation to be in. Just a couple of things I want to add into surgery. We have had some, over the last sort of 10, 15 years, some improvements with surgical treatments where we've been able to be more minimal in how much we kind of need to do surgery. So going back to location, which is why I said at the top, it's so important. The location is probably your number one biological factor that says what you should or shouldn't have, or what are your options available. When you think about treatments, you need to add in, what do you want to do? What is your medical history like, etc. But when we just look at the fibroid, we think about the location. And if it's on the inside of the womb, again, we can actually go through the vagina and up into the womb and actually burn the fibroid off through that. And that actually has pretty good, results. Yes, it is surgery. Yes, you have got an anesthetic, etc. But generally speaking, you haven't actually, well, not generally speaking, you absolutely haven't got any cuts anywhere in your body. So you haven't got a lot of bruising and swelling and recovery time from that. Unfortunately, though, that treatment, and I'm just going to name drop here, it was, owned by Hologic, which is a big women's health tech company, and that specific treatment was called Sonata. It used to be offered on the NHS like over the last year or so, and now it's been removed and it's no longer offered by the NHS.
And that's a great shame, because that would be a very good option, I would have thought, for an awful lot of people.
It's still offered in the US. There is no safety issues. I think it probably comes down to finances.
Wow, I mean, surely that's got to be cheaper than having a hysterectomy.
Well, I mean, it's obviously better for the people that, you know, it's not going to work for every single person, but I think it's a really good point, is that for that individual, it's better because it's far less invasive. However, if you have a hysterectomy, you have completely solved the problem. And when you look at health economics, I'm not talking about what's best for the woman, I'm just talking about society, health economics. That is why I think that historically people with fibroids have been pushed to have a hysterectomy, because then it's done. There's no more coming back into clinic.
It's a
You've got
false
recurrence.
economy, because you've got all of the flow-on effects. I mean, it's all very well to say, well, it was nice and neat and I just had my uterus removed, but then you've got, you know, the flow-on effects of the rest of the pelvic floor. You've got potentially prolapses and things to deal with for the rest of your life. It's an apple and orange argument. It's a false economy to say that.
Exactly, but you're talking about things about pelvic floor issues when we think about bladder health, when we talk about prolapse, difficulties during sex, pain during sex, constipation. But how much of that is picked up by the NHS? How much is, you know, pumped into the NHS to really sort these conditions out? These are conditions, you know, I remember when I was working in urogynecology, purely in this area of prolapse, incontinence, bladder health, etc. And there was just a freeze on all the GPs being able to refer women to us as gynecologists in hospital for these reasons, because it was deemed unnecessary.
Wow, you do wonder who makes these decisions, don't you?
Men.
I wasn't going to say that. It went through my head.
I'm going to say it. I just think, like, I'm going to call a spade a spade. It's a man, for sure. For sure.
Wow. Wow, that absolutely beggars belief, and is completely illogical.
Yeah, and it's you know, not enough attention, money, research has been put into women's health. And so what we find ourselves in this very fragmented, like you're saying, it doesn't make sense necessarily, unless it makes sense for that individual woman, but across the population of women with fibroids, just to say, let's go ahead and do hysterectomies. And that's very much what seems to feel like the situation in a lot of areas in the US, which is why there's been a recent fibroid bill to say, can we stop pushing women into hysterectomies, because that's not necessarily what they want, and it does have consequences. There are implications. It's not like done and dusted and everyone's happy, most of all the women. That's not the case. But the problem comes is that the issues that it causes aren't ones that we're specifically, you know, and historically grab a lot of attention and budget within the NHS. We haven't got these amazing kind of areas of expertise for this. We've got some great doctors doing some great work, but it's still quite hard to access. And if we just look at gynecology as a whole and kind of take kind of bird's eye view, the fact that we've got, you know, nearly 3/4 of a million women sitting waiting to be seen by an NHS doctor on a gynae waiting list. This shows you how much people are really, you know, when I say people, government, NHS, focus, not necessarily your doctor that you're going to see, but just the focus of the health system. How much is it on? It is clearly a massive outlier in its waiting list. But it has been like that, and it's just report after report gets filed saying how many people are on the list, but nothing actually is changing.
No, and you can't actually see it getting any better. Are there other alternatives then, apart from the, well, can you get that privately if women would wish to do that? And B, other, you know, what they used to call it, a D&C, an ablation, things like that? Are there other things in between that might be useful?
Yeah, it's a great question about privately for Sonata. I don't know. In the UK, I'm not sure. I know it's still available in the US. And I'm sure, I don't, you know, to be clear and transparent, I don't do any work with Hologic, I don't know, but I imagine Hologic is working really hard to reinstate it back onto the pathway within the NHS, but potentially privately that could be available. But the key thing for that is that it will only work with certain women if they have a fibroid, which is small to medium and on the inside, because the energy that we use to burn that fibroid has got to be able to get to it. It can't work, and it's got to go all the way through the uterus to then get to the outside fibroid. Yeah, DNC, no, it's not going to work, because it's not actually removing the fibroid. The DNC is actually removing the lining of the womb, and you may get a thickened lining of the womb. You may get, maybe it can be quite helpful for things like polyps, but polyps are, I would say, generally speaking, polyps are more friable than that. They're more delicate. So when you go up and actually do the operation to go in and remove the lining of the womb and do what we call a sweep through, the polyp will likely come off. If you think about a skin tag, you know, if you kind of scrape through your skin, you'll likely get the skin tag to come off, or it will start to bleed. You'll have damaged it in some ways. But fibroids are incredibly hard. I mentioned this in my book, actually, how it always surprised me when I first did hysterectomies with women with fibroids, or a myomectomy where you're only removing the fibroid. And I was really taken aback, because this sounds really weird, I'm such a surgeon at heart, but essentially in surgery, you get used to what different organs feel like. I mean, this is your bread and butter, but a fibroid just feels so alien hard. The only other thing as hard as a fibroid is a really horrid advanced cancer. They get really hard and knobbly. And, you know, it is like a hard rock, a fibroid, because ultimately fibroids are made of their, what I would call origin tissue. What they start off with is fibrous tissue. So it's like really strong fibrous tissue that just gets knotted together like this. And it kind of really condenses in. It's not like soft and spongy at all. So it takes a lot of effort to actually remove that fibroid. It's not going to come away easily. What I said about it starts as fibroid tissue, one thing to mention is that over time, your body may naturally, the fibroid may naturally change. So the actual fibrous tissue can become even more fibrous. So it gets harder. It doesn't grow anymore, but it just gets harder and more condensed. And quite often it will shrink a little bit. Or it can be replaced by lots of different types of tissue. And this is just what we would call normal degeneration of a fibroid. And it's kind of on its stages to actually start to shrink and go away. We typically will see this post-menopause, when obviously the estrogen levels have come right down, which is why so many women may struggle or even ask before starting HRT, I've got a fibroid, what will HRT do to me and my fibroid? Because I know I've got a fibroid, or maybe they've been through the tens of years of really difficulty with fibroids. And then they're in perimenopause thinking, I want to start HRT for other symptoms related to perimenopause, but my God, do I not want to make my fibroid any worse again?
Yes, so that then leads me to the question of management in menopause. Yes. If you are going onto HRT, what are the options there? Are we talking about a Mirena coil again, or?
Yeah, so it's really interesting, actually. So what we would always advise is that women know that there is a chance that what it is really is the estrogen inside. So obviously, just doing a quick recap of HRT, hormone replacement therapy, women will really be wanting estrogen as part of the hormone replacement therapy. That's usually your starting point. You then take the progesterone if you need to protect the lining of your womb. Some women will take progesterone because they have specific perimenopausal symptoms that we think may improve due to perimenopause. So you're always going to start with an estrogen, and often you'll add in a progesterone either to protect your womb if you have a womb and it hasn't been removed for some other reason, or you haven't already, or you've already got a Mirena coil in place because of contraception, and that's your progesterone protecting your womb. But you may be taking it in other ways. And then obviously you may add in testosterone. But I'm going to kind of leave testosterone out of the picture with fibroids, because what we know is testosterone, as far as we know, doesn't impact a fibroid in either a good way or a bad way. So if you're just taking testosterone, I can be pretty sure that we would advise it's not going to impact it. The bit of hormone replacement therapy that will impact it is estrogen. And so we can just think about estrogen now. So when I'm speaking to somebody and looking at prescribing estrogen as part of hormone replacement therapy for a woman, and they've got fibroids, I will always advise that there is a chance your fibroid symptoms may get worse. Now, they may be that they really haven't got any symptoms, or they did have them, they got treatment, things got better, the fibroid shrunk, and they've stayed shrunk. And I'll say there is a possibility that the estrogen in the hormone replacement therapy may reactivate them, may cause them to grow. There is sadly no way yet for us to be able to predict who will likely get a flare-up of fibroid symptoms because of estrogen. What we can say is the more estrogen you take, so if you take one pump, let's say, of an estrogel, and then over the years of perimenopause, you go to 2 and so on, the more estrogen you take, as in the dose of estrogen, the more at risk you are of getting a fibroid flare-up, and the more likely you would get a fibroid flare-up. However, it is not a given. And generally speaking, the way that we find it is that some women will say, my fibroids are so difficult to manage at the moment, I don't want to make anything worse. Then I would say, let's just pause on HRT and actually let's deal with your fibroids first, and then we can sort out the HRT. It's very difficult, just as a heads up, for women, and I don't want women to think that they're being wrongly dismissed, but it's very difficult to deal with perimenopausal symptoms at the same time as dealing with fibroid symptoms. You've got to kind of deal with the fibroid first and then look to start the HRT, because essentially the hormone replacement therapy is going exactly against what you want to be doing for the fibroids. So if someone says they've already got fibroid symptoms, let's sort that out first, then look at HRT once we've sorted that out. But if you haven't got symptoms, or you feel like you can manage with the symptoms you've got, like you're like, maybe my periods have got heavier. Yes, I've now found I've got a fibroid on my ultrasound that I had, for example, if this was you, Fiona, but you're like, actually, it's nothing that I would actively seek treatment for, then go ahead and I would say trial this dose of HRT, trial this dose of estrogen, and it is, let's see what happens. So to be clear, it isn't a definite, no, you can't have HRT if you have fibroids. And I think that's really important to say. But equally, I can't guarantee that your fibroids symptoms won't worsen if you start HRT or if you increase your dose of estrogen in HRT. So you really need to have a great doctor who you are like able to have these conversations with.
Yeah, and I'm guessing that most GPs would probably not be comfortable with this. Do you have to see a gynaecologist for it, or are there, or should GPs be able to manage this?
I think GPs should be able to manage it, because it's not as though, so to be clear, fibroids are not cancer. They do not become cancer. There is no risk, no matter how much estrogen you take, whether you're taking combined oral contraceptive pill for contraception, in your 20s and 30s, or whether you're taking HRT in your 40s and 50s, or both, you are not going to, I can be clear, you are not going to turn that fibroid into a cancer. So you can be 100% sure about it. But what the problem comes is you may make the symptoms worse. And therefore, it's all about being upfront and saying, I can't predict as your doctor if your symptoms will get worse. Let's start a month, let's start 3 months, and let's just keep a really close eye. And this is where you're like being clear on what symptoms could be due to a fibroid. Are you getting any of those? How bad are they? Specifically, how much do they impact your life? Because it's very difficult for any doctor to make a call on that. I've got to know, how is this impacting you? And then I can advise and say, that seems like you're okay at the moment and the perimenopausal symptoms are worse. So why don't we go ahead and try HRT? Let's come back in 1 month and see where you are at with the fibroid symptoms and the perimenopause symptoms, and we'll take it from there.
Is there, I'm thinking, I mean, obviously, I mean, like, you know, me, for example, I have a coil for my progesterone component or progesterone component of my HRT. Is there a logical thought then that you would perhaps, you know, because we know already the BMS says if you're on quite a high dose of estrogen, then you should up your amount of progesterone to match that to protect the endometrium. Is there a logic then to say, okay, we'll start with low estrogen but higher progesterone? And do we know anything about that?
That's a really
also,
good point. Yeah.
Also, are there certain types of progestins that are better at managing fibroids than others?
Yeah, two great questions, but sadly, I don't have the answer to them. We don't know. But it would suggest that, you know, there is potential to say that you would start that HRT pathway with a higher than normal, so to speak, progesterone to estrogen, purely because you're trying to counteract the estrogen that's driving that fibroid growth. But that doesn't exist in any of the fibroid, like NICE guidance, the Royal College of Obs and Gynae guidance. That's not something that's recommended at the moment. It doesn't mean that it wouldn't work, it's just that hasn't been looked at yet. And similarly, working out the type of progesterone. And I think understanding that in different phases of life, you know, there's something quite different, as we know, of the hormone kind of situation with a woman in perimenopause compared to in her 20s, for example, compared to postnatally. And it's just about, we don't yet know what is better at what time. But what we do know, looking at something completely different and for this moment, is a company that's looking at personalized contraception, which has come about from the fact that women, you know, and myself included, can be on the oral contraceptive pill combined, so estrogen and progesterone, not have a single side effect. I haven't got any spotting, any abnormal bleeding. And there will be women where you will trial all different types of pill, contraceptive pill, and they will have side effects, you know, migraines, they will have, you know, bleeding, spotting, etc. And so what we know is there must be something else that's going on here, which is why some women were, you know, are impacted in some ways and other aren't. And what we are starting to see is some clear genetic understanding of some people have certain kind of setup of their genes that makes them more prone to have certain side effects. But it's just so many layers. It's like, what's your baseline genes? What and where are your fibroids? What are your symptoms from the fibroids? And then on top of that, what phase of life are you in? Where are you at perimenopause? How are those symptoms of perimenopause? And how do you respond to HRT? It's just a complexity, which is why I get so frustrated when people say this can all be done in 10 bloody minutes. Sorry, of course it can't. Like,
it really can't.
Just running through all of these layers. And it's like, you know, this is all I do, but yet every single person is different. There is a slight variation, and you've got to think it through, and you've got to explain as much as you know and say, this is why we're going to do it this way, and let's see how that goes. And it takes time. And, you know, and I think that there isn't that time in the system to enable it. And also that is why I wrote the book, because I really wanted women to understand a lot more about how their bodies work, how fibroids, which are so common, cause these problems, and therefore why different things, like why you get different investigations, why you get different treatment options from your mate, your sister, your mum, etc. Because everybody is so different, and we're trying to, as much as possible, personalize the treatment. And it isn't just your biology and your genetics, it's also about what your job is, what your responsibilities are, what your medical history is, what's your general feeling. Do you want to have children? Do you want to even have surgery? Everybody varies so much, and it's really important to take those elements into consideration.
All right. Before we wrap up, I've got one more question for you, and that is that often people are told when they've got incredibly heavy breathing and things like that, that they should just add tranexamic acid into their regime and all will be well. I see you're not very good poker face there. So I'm guessing if people are being told that they should actually ask. I mean, I've been told that when I remember when I had the year of bleeding endlessly. It was like, well, why don't you just take tranexamic acid? And because that's helped stop bleeding. And I thought, well, you're not dealing with the root cause of the problem.
Exactly.
Is that the same when it comes to fibroids?
Exactly the same. You're not dealing with it. So tranexamic acid is a great way in all of our body, and we use it, you know, if somebody had a road traffic accident and was bleeding profusely, I mean, I don't know, I haven't worked in A&E for a long time, but the theory is that you could use tranexamic acid. It's not something specific to women. It's not something specific to our reproductive organs. It is something that works inside our body about how our blood clots. So how does it form a scab? And if you take more tranexamic acid, your body is more likely to stop bleeding or not bleed as much because it clots a bit more. The downside is obviously you're at more risk of clots when we think of things like BVTs and pulmonary embolus. But essentially, that's the theory behind it. We can use it in all different ways depending on where somebody is bleeding from in their whole body. It's not specific to fibroids. But having said that, tranexamic acid is fantastic for, you've just rocked up to your GP appointment, you've told me how bad your periods are, I'm now sending off a referral to get an ultrasound, I'm sending off a referral to get seen by a gynaecologist. There is some waiting time. Therefore, let's use tranexamic acid. 100%. That's why I love tranexamic acid. I would put you on tranexamic acid. I'd put you on mefenamic acid, which even though they sound the same, are completely different. Tranexamic acid is about bleeding. Mefenamic acid is about helping you. It works a little bit like ibuprofen. It helps you reduce the pain. And so you get this combo, which I would always give women: tranexamic acid to help with the bleeding, mefenamic acid to help with the pain, and iron tablets to try and at least stop your hemoglobin, your blood level, reducing any further. And I would send off your bloods of hemoglobin, full iron studies, and also check your thyroid as well, because if that's playing up, that's only going to make everything worse, because when your thyroid plays up, it affects bleeding overall. And so that would be all what I would do as part of while we are waiting to get to the next stage, where the next stage is, let's get whatever's going on diagnosed. So we're going to probably send you, well, we definitely have to send you for an ultrasound of your tummy and your pelvis so we can look inside the wound. But they may be thinking, oh, well, it could be some other things going on. So you may get sent for some other investigations as well. But that is the only time, or if you're waiting to have treatment, you should be on it. But as soon as it's diagnosed, if you're then diagnosed as fibroid, you need to be saying, I need to be taken off my medication that stops me from bleeding so heavily and feeling the pain so much and lifting my iron levels, because now, doctor, you're actually going to treat me, because we know the fibroids that have just been diagnosed is what's causing it. And tranexamic acid is not a treatment for fibroids. It's just a kind of waiting period. Yeah, exactly. And it's great for that, but you know, that is the only time you should be using it. And women who come to me saying, I've been on tranexamic acid for the last 5 years that my GP keeps repeating prescription for me, and I've just finally got to this gynae appointment, or finally got the GP to do a referral to gynae, is there anything else? And I just want to pull my hair out going, of course there's something else, because tranexamic acid isn't even a treatment for your fibroids. It's treating your heavy bleeding, but it's not treating the root cause, as you say. And it's really important that women are aware that they've got to get off the tranexamic acid and actually onto a treatment for the fibroid. Now, the only thing I will just say as an exception is, if you are on tranexamic acid and you're going for medical treatment, depending on what that medical treatment is, I will often say, let's try, depending on the size, and if somebody wanted, if we got to a place where somebody was like ready to try to have the Mirena intrauterine device inserted and go with that as a trial of that treatment, I would say stay on the tranexamic acid as well. So you might get combination, but the idea that somebody is solely being treated with tranexamic acid is ridiculous and wrong, and it's got to stop.
Now
that's my rant for today finished.
Well, Well done, you. Well, I think I still have a list of a whole. We have to. I'm sorry, we've got to follow this up because
Yes.
I have a whole page of other questions that we haven't even got to here. We're already over an hour. My husband keeps on telling me when I say, "Oh, it won't take an hour," and he says, "You always say that."
And I was thinking that actually during this, I was like, no, we actually always take beyond an hour. So yeah, I chat too much. That's my thing. But don't worry, because it's now all in a book. I was able to chat and chat and chat in my book. So please do have a read. I talk a lot of this, but I'm able to walk people through it in a lot more detail. And as I say, adding checkpoints and little questions in of things like, these are the things I should be asking the doctor. This is the information I need to know. These are the considerations I need to take on board, because it isn't just about what's going on in your body. It's what you feel about it, and it's about how it's impacting you as well.
And if people want to get the book, where can they find it?
Yeah, so it's available to pre-order. It comes out July the 2nd, so in just under 2 months' time. But as I say, you can pre-order now. You can just find it on Amazon, Fibroids, Dr. Michelle Griffin, you'll find it there. But there's also a link in my Instagram bio. So it's at the Dr. Call, and you will find it in the link there.
Brilliant. All right.
Thank you so much. It's been wonderful as ever. And I look forward to our next one.
All right, see you soon.
Take care. Thank you.